In this episode of Crit Care Bites, we'll be discussing about shock. We'll be going through what shock entails, the different causes of shock, important hemodynamic targets, therapeutic interventions like fluids, vasopressors, and inotropes, and finally we'll be looking into different shock states. So beginning firstly with what is shock. Shock is a state of circulatory insufficiency that ultimately results in inadequate oxygen delivery to meet cellular metabolic needs, causing tissue hypoxia and organ dysfunction. It is often, but not always, associated with hypotension that is defined by a systolic blood pressure of less than 90 millimeters mercury or mean arterial pressure of less than 65 millimeters mercury. Useful clinical markers of shock, especially at the bedside, includes alteration of mental status, a prolonged capillary refill time of more than 3 seconds, a reduction in urine output, as well as lactate elevation of more than 2 millimoles per liter. Lactate elevation is a common occurrence in shock states due to anaerobic glycolysis, as well as stress-related adrenergic aerobic glycolysis, causing excessive pyruvate generation, which ultimately gets converted to lactate through the Cori cycle. Lactate elevation also occurs in cytopathic states like cyanide poisoning or in local ischemia like in ischemic bowel, or due to type B hyperlactatemia in disease states like hematological malignancies, liver failure, retroviral disease. With certain medications like metformin, salbutamol, and adrenaline, as well as inborn errors of metabolism. As such, it is important to consider these other causes of lactate elevation apart from circulatory insufficiency causing shock. The clinical utility of lactate in shock can be considered from a diagnostic, prognostic, and monitoring point of view. Lactate elevation aids in the diagnosis of shock, and in certain shock states like cardiogenic shock may sometimes even precede hypotension. The degree of lactate elevation is also prognosticative, with the diagram here demonstrating the cumulative mortality risk with both hypotension and lactate elevation. And finally, the rates of lactate elevation, or rather lactate clearance, can be used as a monitoring data point where lactate reduction of 10% over 2 hours suggests response to initial resuscitative measures. Capillary refill time is another useful bedside tool that can be used to assess perfusion adequacy. The Andromeda shock study shown here demonstrates that both lactate-guided and capillary refill time-guided resuscitation are acceptable. In this study, capillary refill time was measured by applying firm pressure to the ventral surface of the right index finger, distal phalanx, with a glass microscope slide until the skin was blank and then maintained for 10 seconds. The time for return of the normal skin color was registered with a chronometer, and a refill time greater than 3 seconds was defined as abnormal. And although this may not be practical at the bedside, it is important to ensure that adequate pressure is exerted and that the patient is appropriately monitored in terms of capillary refill. So next we'll be delving into the different causes of shock. So the classical classification of shock based on hypovolemia, distributive, cardiogenic, and obstructive shock provides a basic framework, but has limitations as oftentimes multiple pathophysiological mechanisms may occur concurrently. An alternative proposed classification would be to think from a physiological standpoint of a tank, pump, and pipe analogy, respectively corresponding to preload cardiac function as well as vessel tone. Shock can also be classified as high output, usually in vasodilatory states where patients are warm peripherally, or low output states like in cardiogenic, hypovolemic, and obstructive shock where patients oftentimes present with cold peripheries. Importantly, multiple contributory etiologies of shock may coexist concurrently. For example, a patient in septic shock may be hypovolemic because of poor oral intake or ongoing GI losses leading up to the admission, and may also have a contributory cardiogenic component, either due to septic cardiomyopathy or a baseline reduced ejection fraction. Hence, in assessing a patient, the aim is not simply to identify one cause of shock, but sometimes to evaluate the relative contribution of multiple etiologies to the patient's shock state. So this slide captures the different important aspects of history, physical examination, and laboratory and imaging investigations to elucidate the different causes within the different buckets of hypovolemic, distributive, cardiogenic, and obstructive shock. So bedside ultrasound is a valuable extension of the physical examination to differentiate the different causes of shock. Pronounced IVC variability and reduced chamber sizes tend to occur in hypovolemia, as seen here. A markedly reduced ejection fraction supports an element of cardiogenic shock. The presence of a large pericardial effusion with chamber collapse and RV enlargement with septal flattening suggests tamponade and acute cor pulmonale respectively, and a hyperdynamic circulation as seen here may be observed in distributive shock. So next, after covering the different causes of shock, we'll be looking at important hemodynamic targets, namely pressure, flow, and oxygen. I think we're all familiar with the importance of maintaining a blood pressure in shock states. However, in the next couple of slides, I would also like to highlight the importance of global oxygen delivery as well as flow targets, and these are especially important in patients with complex shock physiology. A minimum mean arterial pressure is needed to provide a pressure gradient to maintain tissue perfusion at the level of the organ capillaries. Vital organs like the kidney and brain operate within a blood pressure autoregulatory range where blood flow can be kept constant, and this is described to have a lower limit of approximately 60 mm mercury. Of note, this may be shifted upwards in chronic hypertension. The landmark sepsis PAM study actually showed no mortality difference between targeting a mean arterial pressure of 65 to 70 versus 80 to 85 mm mercury. However, there was higher renal replacement therapy requirements among patients who were chronically hypertensive in the lower blood pressure arm, and there was a higher incidence of atrial fibrillation in the higher blood pressure arm. As such, practically speaking, a mean arterial pressure target of 65 mm mercury serves as a ballpark guide for most patients. However, blood pressure targets should be individualized based on the patient's physiological processes and requirements. For example, lower blood pressure targets should be tolerated in the context of bleeding to prevent clot dislodgement or exacerbation of bleeding, and perhaps higher targets can be considered in patients with chronic hypertension, especially if a renal protective intent is desired. Organ-specific perfusion should also be considered in conditions like acute brain injury and intra-abdominal hypertension. Finally, it is important to bear in mind that maintaining a blood pressure is ultimately a means to an end of maintaining target organ perfusion and function. Hence, reviewing the blood pressure target relative to end organ requirements is key. Next, looking at oxygen delivery. Global oxygen delivery is determined by the following equation shown on this slide, of which the main components are cardiac output, hemoglobin, as well as oxygen saturation. The determinants of cardiac output can be further broken down into heart rate and stroke volume, where stroke volume is determined by contractility, preload, and afterload. Central venous oximetry is the oxygen saturation of venous blood obtained via an internal jugular venous catheter. It represents blood that has undergone oxygen extraction after traveling around the body back to the heart, and hence provides an indication of global oxygen delivery and consumption matching. Normal values are usually between 70 to 80% because the extraction ratio in a normal state is about that of 1:5. Low central venous oximetry results from reduced oxygen delivery, such as in anemia, severe hypoxemia, or low cardiac output states, which can be due to hypovolemia, heart failure, or even obstructive shock, or from an increased oxygen consumption, such as in seizures, fever, or agitation. Conversely, a high central venous oximetry can result from increased oxygen delivery or reduced oxygen consumption, such as in hypothermia or in states of impaired oxygen utilization, such as cyanide poisoning or microcirculatory dysfunction. After considering pressure, and oxygen delivery targets, the flow target relates to cardiac output, which sits as one of the important components of the oxygen delivery equation as previously discussed. The importance of paying attention to a flow target is that in certain clinical situations, like in cardiogenic shock or mixed shock, focusing solely on a blood pressure target can paradoxically impair global blood flow and hence tissue perfusion, resulting in a state of hemodynamic incoherence where blood pressure goals may be met at the expense of global cardiac output and oxygen delivery. Flow can be assessed using various methods such as cardiac output monitors like pulse contour analysis, echocardiography, or a tool called the CO2 gap, which we'll discuss next. The CO2 gap, or PCVA CO2 gap, is the difference between the partial pressure of carbon dioxide from an internal jugular venous sample and an arterial blood gas. This value is inversely proportional to cardiac output based on the Fick equation that states that carbon dioxide excretion should equal the product of cardiac output and venous to arterial CO2 difference. As such, when ventilation is stable, a low cardiac output state causes an elevated CO2 gap of more than 6 mm mercury. Physiologically, this can be explained by the CO2 stagnation phenomenon, wherein delayed transit time of red blood cells in a low flow state leads to higher addition of carbon dioxide per unit of blood flowing through efferent microvessels, causing elevation of dissolved CO2 in the blood that returns to the heart, ultimately resulting in a higher concentration of dissolved carbon dioxide in blood that is sampled from the IJ venous sample. The clinical utility of central venous oximetry and the CO2 gap can be applied in suspected cases of mixed shock or if patients are not responding to initial therapy. This flowchart shown here proposes an algorithm that classifies patients into low, normal, and high central venous oximetry states. When central venous oximetry is low, components of the oxygen delivery equation should be evaluated and addressed. When it is normal, some degree of flow impairment may still be present, and an elevated CO2 gap may suggest a role for cardiac output augmentation. These markers should always be interpreted in the context of the patient's other clinical parameters and overall trajectory. So having gone through hemodynamic targets, we'll now be looking at the different interventions that can be administered for patients in shock states. We'll now be looking at fluids. Fluid therapy is the most common therapeutic intervention in shock. It is important to bear in mind that the aim of a fluid bolus is to augment stroke volume and hence cardiac output. This is achieved when a preload increase is met by the state of the heart being along the steep part of the Frank-Starling curve. Initial fluid resuscitation can usually be carried out using 20 to 30 mL per kg body weight of crystalloids for most patients, especially in the context of distributive or hypovolemic shock. After initial resuscitation, concepts of fluid responsiveness and fluid tolerance become important, and these will be discussed in the next few slides. Fluid responsiveness describes a state where fluid loading translates into actual increase in stroke volume. Quantitatively, it is defined as a 10 to 15% increase in stroke volume in response to 500 mL of fluids administered over 15 to 30 minutes. Studies have shown that only about 50% of ICU patients are fluid responsive by the time they are resuscitated in the ED or general ward, and excessive fluids have been shown to result in complications such as pulmonary edema and renal impairment. As such, assessing fluid responsiveness is important to ensure that only patients who would benefit from additional fluids receive these additional fluids. Methods of assessing fluid responsiveness can be broadly classified into static and dynamic measures, of which static measures like a central venous pressure or pulmonary capillary wedge pressure have been shown to be inferior and are thus not recommended to be used. Dynamic methods can be further classified into methods that invoke an increase in preload, such as via a fluid bolus, passive leg raise, and methods that make use of heart-lung interactions, such as pulse pressure variation and stroke volume variation. In the next few slides, we'll be going through in some detail about the different methods of assessing fluid responsiveness. The passive leg raise produces an autotransfusion of about 300 mL of blood as blood is mobilized from the splanchnic and lower limb venous circulation back to the heart, as a patient is transferred from a semi-recumbent position, as seen here, to a position where the trunk is horizontal and the lower limbs are elevated at 30 to 45 degrees. Subsequent repositioning back to the semi-recumbent position is recommended to ascertain return of cardiac output back to baseline. These maneuvers should ideally be carried out with an electronic bed rather than physically lifting the patient's legs to minimize any confounding by pain or physical stimuli. Response measures to passive leg raise should ideally be a marker of stroke volume or cardiac output rather than blood pressure. And examples of these include the use of pulse contour analysis like a FlowTrac, or ultrasound methods like measuring the patient's left ventricular outflow tract velocity time integral. In intubated patients, a rise of the end tidal CO2 by 5% or 2 millimeters mercury actually suggests an augmentation and a response in terms of cardiac output. A key advantage of this test is that it does not depend on ventilation and heart rate and remains reliable in patients who are spontaneously breathing or even in those with cardiac arrhythmias. The next common method for assessment of fluid responsiveness is pulse pressure variation and stroke volume variation. This method makes use of heart-lung interactions under conditions of invasive mechanical ventilation. Essentially, positive pressure insufflation reduces venous return and hence preload, causing a fall in cardiac output, while the reverse in expiration occurs subsequently. As such, there will be fluctuations in cardiac output across the respiratory cycle, and these fluctuations are exaggerated in fluid responsive states, where a 12% of stroke volume variation or pulse pressure variation is suggested to indicate fluid responsiveness. Pulse pressure variation can be automatically calculated in some newer ICU monitors, while stroke volume variation can be obtained from pulse contour analysis. Of note, in order for these measures to be accurate, a few preconditions called conditions of respirophasic variation need to be met, and these include that the patient should be passive on the ventilator, have tidal volumes of at least 8 mL per kg ideal body weight, and should have absence of atrial fibrillation or right ventricular dysfunction. These confounders can result in either false positive or false negative readings. For example, if the patient is actively breathing, different sizes of breath may result in positive variations, or if a patient is actually ventilated at low tidal volumes, the low tidal volumes may not result in an adequate change in the cardiac output, and this may result in a false negative state. Atrial fibrillation and right ventricular dysfunction in themselves cause beat-to-beat changes in terms of the cardiac output and false positive reading results. IVC variability is commonly used to assess for fluid responsiveness. I think, however, it is important to note that the supportive evidence is much less robust than the earlier described methods of passive leg raise or pulse pressure and stroke volume variation because of different confounders. Different cutoff values have also been described in different settings and different studies. Of note, we look at a collapsibility index in patients who are spontaneously breathing and a distensibility index in patients who are passive on positive pressure ventilation. These values are likely most useful in their extremes, and when they are borderline, perhaps may not be the best indicator of fluid responsiveness. Other assessment methods described in the ICU literature include mini fluid challenge, and expiratory occlusion test, and tidal volume challenge, which are described and summarized in this slide. So, putting everything together, this schematic summarizes the different assessment methods into a practical algorithm, highlighting when testing for fluid responsiveness is appropriate and when should the different tests be employed. Of note, it is important to highlight that when hypovolemia or fluid losses is obvious, one should not actually be testing for fluid responsiveness. Testing for fluid responsiveness is most useful after the initial resuscitation has been conducted and where the risk-benefit profile of a further bolus of fluid is less clear. While measures of fluid responsiveness provides a suggestion of the likely benefit of an additional fluid bolus, The concept of fluid tolerance focuses on the potential harm that might result. Fluid tolerance refers to the ability to handle fluid administration without developing adverse effects like pulmonary edema, renal impairment, and abdominal hypertension. This can be assessed using clinical parameters such as the requirement for supplemental oxygen, clinical features of pulmonary edema, as well as imaging tests like chest radiograph and bedside ultrasound. The presence of multiple B lines, usually described as more than 3 per rib space, or an elevated VEXAS score suggests higher risk for fluid intolerance. And this schematic here shown on the right highlights the importance of a gradation between fluid responsiveness and fluid intolerance. And patients need not necessarily have a binary cutoff between the two states, and in fact, they may overlap. As such, even if a patient is fluid responsive, if the risk of fluid intolerance is high, for example, a patient who is already requiring significant amount of oxygenation support, additional fluid boluses may actually render more harm than benefit in these states. So besides the amount of fluids, the choice of fluids is equally important. And there is actually very much to cover in terms of what the ICU literature says in this space. But a quick simplified summary can be captured in these few salient points. Firstly, crystalloids are generally given over colloids as an initial resuscitative fluid because of its relative similar efficacy as shown in the crystal study and its relatively lower cost. An exception would perhaps be in hemorrhagic shock, where blood product should be given as soon as possible. Secondly, in most instances, balanced crystalloids are favored over normal saline. This is on the basis of the high chloride load in normal or 0.9% saline, predisposing to hyperchloremic metabolic acidosis and renal impairment. And even though the aggregate clinical evidence of benefit is fairly tenuous, in most instances where balanced crystalloids is accessible, this is preferred, especially when large amounts of fluids are going to be administered. Normal saline has a potential role in acute brain injury when perhaps more hypertonic balanced solutions are not available, or in patients with a metabolic alkalosis with chloride depletion. Thirdly, hypotonic solutions should be avoided in acute brain injury because of the risk of worsening cerebral edema. And the SAFE study also demonstrated possible harm with lower concentrations like 4 or 5% albumin. Albumin can be considered as a second-line resuscitative fluid in septic shock as supported by the Surviving Sepsis Guidelines, with some supportive evidence gleaned from the secondary analysis of the SAFE and ALBEOS studies. And finally, hydroxyethoxide should be avoided because of increased risk of renal impairment and mortality. So moving on from fluid therapy, we will now discuss about vasopressors and inotropes in the management of different shock states. I think it is important to distinguish between the two classes of vasoactive medications. Vasopressors increase vasomotor tone and primarily serve to increase a patient's blood pressure or peripheral vascular resistance, while inotropes act by increasing cardiac contractility to augment cardiac output. Vasopressors at high doses may actually reduce cardiac output if afterload is too high, and inotropes, especially inodilators, may reduce blood pressure because of its vasodilatory properties. It is hence important to titrate each agent to appropriate targets and to monitor the global impact based on the earlier described hemodynamic targets of pressure, oxygen delivery, and flow. Generally speaking, noradrenaline is a reasonable first-line vasoactive agent in most shock states, and these medications can either be given as push boluses or infusions when resuscitating a patient in shock. The subsequent few slides will cover commonly used vasopressors and inotropes in the ICU. Starting with the pure vasopressors, vasopressin and phenylephrine fall into this category. Vasopressin, which acts on the V1 and V2 receptors, is often used as a second-line agent in septic shock for its catecholamine-sparing effect and to address relative vasopressin deficiency that is theorized in septic shock. It is usually initiated when noradrenaline doses are in excess of 0.25 micrograms per kg per minute, and oftentimes is administered at a dose of 0.03 units per minute or 1.8 units per hour. Doses beyond 2.4 units per hour have been described to be associated with increased risk of cardiac, digital, and gut ischemia. The practice of vasopressor weaning in the context of noradrenaline and vasopressin being on board is variable. Most providers will keep vasopressin on until noradrenaline has been weaned down significantly to usually less than 0.1 micrograms per kg per minute, at which point some will stop the vasopressin completely, while others may choose to taper the vasopressin gradually. The optimal approach is yet to be established, hence there is practice variability. Phenylephrine, on the other hand, is a pure alpha-1 agonist. It is commonly used in the initial resuscitation of hypotensive patients, oftentimes in the form of push boluses of 100 to 200 micrograms each time. It can also be run as an infusion and is sometimes administered peripherally. Given its pure alpha-1 effect, it may induce a reflex bradycardia and hence should be used cautiously in patients with low heart rates. The next set of medications have some degree of vasopressor and inotropic effects. Noradrenaline has a predominant alpha-1 and some modest beta-1 effect, and as mentioned, it is the initial resuscitative or vasoactive drug of choice in most shock states. Adrenaline, on the other hand, has a strong beta-1 effect. Its effect on vessel tone has been described to be dose-dependent, where higher doses are associated with alpha-1 activity. Adrenaline is indicated in anaphylactic shock, as well as bradycardic states with hemodynamic compromise as per the ACLS guidelines. It can also be used as a third-line agent in septic shock, especially when there is an element of impaired cardiac contractility. Adrenaline can be used as push boluses and be run as an IV infusion as well. It tends to cause tachycardia and may be associated with lactate elevation at high doses. As such, caution should be exercised with the interpretation of lactate values in this context. Dopamine has been described to have varying dose-dependent effects. At low doses of up to about 5 micrograms per kg per minute has been described to increase renal and splenic blood flow and may paradoxically actually cause a reduction in blood pressure. At intermediate doses between 5 to 10 micrograms per kg per minute, its beta-1 effects of inotropy and chronotropy predominate, and only at higher doses of 10 to 20 micrograms per kg per minute are its alpha-1 vasoconstrictive properties present. Dopamine is commonly used outside the ICU when central access isn't available or as a temporizing measure when other vasoactive drugs may not be available. From an evidence-based standpoint, however, the SOAP2 study actually demonstrated increased risk of arrhythmogenicity and higher mortality rates in cardiogenic shock when compared to noradrenaline. Hence, use with dopamine should be exercised with caution. The inodilators, namely dobutamine and nurenone, increase cardiac contractility but actually cause systemic vasodilation and hence may cause a fall in blood pressure upon initiation. These agents should be considered when there is an element of cardiogenic shock and should be titrated to a marker of flow, either with advanced cardiac output monitoring, echocardiographic parameters, or a CO2 gap. It should not be titrated to a blood pressure. Because of its vasodilatory properties, these agents are often used in conjunction with noradrenaline that is first started to ensure stabilization of blood pressure. Both agents are reasonable when cardiac output augmentation is required, with dopamine being considered more easily titratable and less affected by renal clearance, and nurenone being favorable in right ventricular dysfunction because of its pulmonary vasodilatory properties. These two charts summarize the relative effects of various vasoactive drugs in terms of its effect on vessel tone and cardiac contractility. And this slide summarizes some of the landmark trials relevant to vasopressors and inotropes. Having gone through the different therapeutic interventions, we will now consider the management considerations in a few specific shock states. Starting with septic shock, which is probably one of the most commonest causes of shock in the ICU, this results from a dysregulated host response to an infection, causing life-threatening organ dysfunction. Beyond supportive hemodynamic management, source identification and source control alongside empirical antimicrobial therapy are key. Recommendations from the Surviving Sepsis Guidelines suggest aggressive initial fluid resuscitation with crystalloids, followed by albumin if required. And as previously discussed, noradrenaline is usually the first-line vasopressor of choice, with vasopressin and hydrocortisone added when noradrenaline requirements exceed that of 0.25 micrograms per kg per minute. Adrenaline is suggested as a possible third-line agent. One cannot discuss the management of septic shock without mention of the concept of early goal-directed therapy that came out of Emanuel Rivers' seminal publication in NEJM in 2001 that demonstrated a 16% absolute risk reduction in mortality with goal-directed bundle care. And although the subsequent ARISE, PROMISE, and PROCESS studies failed to show similar benefit and challenged some of the components in the initial resuscitative bundle, the concept of early goal-directed care has become a mainstay in how we approach patients in septic shock and different shock states. Moving on to cardiogenic shock that is characterized by a reduced cardiac index with accompanying features of shock, the recent SCAI classification grades patients from A to E, namely at risk, beginning, classic, deteriorating, and extremis, and provides a standardized means of communicating the state of cardiogenic shock a patient is in. Advanced cardiac output monitoring, usually in the form of a pulmonary artery catheter, is recommended in the monitoring, phenotyping, and management of patients with severe cardiogenic shock. And management principles include treating the underlying etiology, commonly revascularization in the context of acute myocardial infarction, judicious fluid therapy, where early consideration of assessment of fluid responsiveness and tolerance is indicated, and noradrenaline usually being the first-line agent in cardiogenic shock, with addition of inodilators like dobutamine and milrinone as previously discussed to improve cardiac output and global oxygen delivery. And to reinforce once again, the inotropes or inodilators should be titrated based on the flow measure, coupled with monitoring of global oxygen supply demand matching and end organ perfusion markers, rather than solely looking at blood pressure. And finally, in patients with severe cardiogenic shock refractory to medical therapy, mechanical circulatory support in the form of intra-aortic balloon pump, percutaneous ventricular assist device, or VA ECMO should be considered. I wanted to end off with a quick word on mixed shock states. As mentioned earlier in this lecture series, patients in ICUs these days tend to have multifactorial shock. The challenge is to phenotype the relative magnitude of each etiology in order to tailor therapy, specifically looking at fluids, vasopressors, and cardiac output augmentation appropriately. This can be achieved through multimodal assessment with bedside ultrasound, advanced cardiac output monitoring, with therapeutic interventions guided by appropriate targets. When administering fluids, we consider fluid responsiveness and fluid tolerance. When we titrate vasopressors, we titrate it to a mean arterial pressure most of the time. And when we administer inotropes, we should be looking at a cardiac output measure, either using ultrasound, advanced hemodynamic monitoring, or CO2 gap and central venous oximetry. And this is a summary slide that summarizes what we've gone through. Beginning with looking at what shock entails, it is a state ultimately not of hypotension, but that of circulatory insufficiency that causes an oxygen supply-demand mismatch, causing end organ hypoxia and dysfunction. It is often accompanied by lactate elevation too. Causes of shock can be classified into hypovolemic, vasodilatory, obstructive, and cardiogenic, and multiple causes may coexist. Ultrasound evaluation is helpful in distinguishing these causes. The important hemodynamic targets of blood pressure, flow, and global oxygen delivery and supply-demand matching has also been discussed. In terms of fluid administration, a fluid bolus is intended to increase stroke volume if a patient is in a fluid-responsive state, and this can be assessed using dynamic measures like passive leg raise, pulse pressure, and stroke volume variation when appropriate conditions are met. It is also important to assess for fluid tolerance, and generally balanced crystalloids are favored. In terms of vasopressors and inotropes, noradrenaline is a reasonable first-line agent in most shock states, and vasopressors increase vascular tone while inotropes increase cardiac contractility, and appropriate target measures should be employed when titrating these medications. In terms of septic shock, source identification, control, and antibiotics are key. Beyond fluid therapy, noradrenaline is usually the first line, and vasopressin and steroids are added when noradrenaline doses are beyond 0.25 micrograms per kg per minute. And in terms of cardiogenic shock, we must always treat the underlying cause, consider advanced cardiac output monitoring, usually in the form of a PA catheter. And in terms of vasoactive agents, noradrenaline is usually started to maintain a blood pressure before dobutamine and murinone are added. And importantly, mechanical circulatory support should be considered in severe disease. This comes to the end of the presentation. Thank you very much.